Good afternoon. When imaging the bone in the head and neck region of a craniosynostosis patient, computer tomography is usually the exam of choice. CT is widespread available. It has a short acquisition time. I'm not tall enough. Okay. And it allows to automatically reconstruct multiplanar and bone rendering images that aid both the diagnosis and the surgical planning. Also, CT provides an excellent assessment of the bony structures. On the other side, CT exposes patients to ionizing radiations with possible long-term damages that are particularly worrisome in young patients. When performed under the age of 5, from 7 to 17, radiation-related solid tumors are expected every 10,000 head CTs and 2 leukemias. If we consider this data, we understand why reducing the radiation dose is particularly important, especially in children that undergo repeated examinations. That is the case of craniosynostosis patients. In order to reach this goal, many non-radiating solutions have been proposed, among them MRI. Standard MRI sequences do not provide sufficient detail to investigate the cortical bone due to its very rapid signal decay. For this reason, dedicated sequences have been developed, including black bone MRI. They have been applied in a variety of conditions, including craniosynostosis. Black bone MRI is a three-dimensional isotropic gradient echo sequence that allows to investigate the temporal bone. As first described by Ely and co-workers, black bone has a short echo time, short repetition time, and a small slip angle. As a consequence, the bone appears as black, hypointense, while both water and fat are suppressed, resulting in an uniform soft tissues background. Therefore, the interface between the bone and the soft tissues is enhanced. Black bone was originally developed for GE Medical System, but is now available for other vendors as well, like Siemens or Philips. Black bone MRI has been proposed to investigate the cranial vault suture in craniosynostosis patients, as previously mentioned by Dr. Chitz. This is based on the observation that patent sutures appear as hyperintense, that is the yellow arrows, while both bone and synostosis sutures appear as hypointense, that is the blue arrow. Some studies have compared black bone to CT in the cranial vault imaging of craniosynostosis patients with promising results. An MRI protocol including black bone has several advantages over CT. The first one, it does not radiate like CT does. Then, as it is a three-dimensional isometric sequence, it allows automatically reconstructing multiplanar images. Black bone models have been used in the surgical planning of patients with isolated trichronocephaly, and the intracranial content can be better depicted within the same MRI examinations, while abnormalities might be missed on CT due to the lower parenchymal resolution. Black bone also has a relatively short duration, from 4 to 5 minutes. A 12-minute protocol has been proposed to image craniosynostosis patients, thus reducing the need of general anesthesia, especially in young infants that can be imaged within the feed and wrap method. Black bone, anyway, has some limitations. The first one, it is a gradient echo sequence, so the structures at the air-bone interface are, the visualization of the structures at the air-bone interface is limited. Also, there is currently no automated 3D rendering of the skull in children. Some manual or semi-automated techniques are available, but they are time-consuming. Additionally, some authors found the segmentation of the skull difficult in young infants due to the thin bone with high water content. Black bone potential has been explored on the temporal bone by Connor and co-authors on a population of adult patients. They found that black bone could clearly delineate the course of the mastoid tract of the facial nerve canal in all cases and of the chorda tympani canal in 72% of cases. The course on black bone corresponded to the one on CT in all cases except one. When dealing with the craniosynostosis patients, temporal bone assessment might play a role in the management of the patient. Temporal bone malformations have been described in craniosynostosis patients in association with hearing loss, as previously mentioned by Dr. Brotto. Malformations reported in literature include external auditory canal atresia, ossicular chain malformations, cochlear abnormalities, dysplasia of the structures of the posterior labyrinth. When imaging the temporal bone, CT is usually the modality of choice, while non-radiating solutions could be considered in patients that need to undergo often repeated examinations, like craniosynostosis patients. In a project funded by the European Research Network Mobility Fellowship Program that took place in the Erasmus Medical Center of Rotterdam, we aimed to determine the black bone's potential in evaluating the normal and pathological temporal bone structures in patients with craniosynostosis. The Erasmus Medical Center database on craniosynostosis was retrospectively screened, and we included patients that underwent both CT and black bone MRI within 1 year. Patients with postoperative temporal bone, low quality exams, or inadequate slice thickness were excluded. 3 raters evaluated blindly CTs and black bone MRIs independently and assessed both the image quality and whether the considered temporal bone structures were normal or abnormal. Temporal bone abnormalities were recorded and disagreements were solved by a senior pediatric neuroradiologist. Our population was made of 48 patients, the majority of them around 60% male. The mean age at imaging was around 32 months, while the mean time between black bone and CT was around 80 days. 11 patients were imaged on the same day. 73% of our population was made of syndromic craniosynostosis. While the statistical analysis is still in progress, we can make some preliminary evaluations on black bone MRI and reduce some normal and pathological temporal bone structures. This is the typical appearance of a black bone MRI on the temporal bone and of an inverted black bone that provides similar visual appearance that is similar to the CT. Some structures that are typically investigated on CT are nicely visible on black bone MRI, including the aortic capsule that is nicely hyperintense on inverted black bone and is usually not evaluable on MRI, the cochlea and the modiolus that is nicely enhanced on inverted black bone, the superior semicircular canal, the lateral semicircular canal, the posterior semicircular canal. In this patient with the Apert syndrome, we can identify the superior semicircular canals and follow them caudally until the level of the vestibule and lateral semicircular canals. On the right, we can see that the vestibule and the lateral semicircular canal are forming a single cavity consistent with a beautiful image of lateral semicircular canal vestibule dysplasia. On the left, the vestibule is also enlarged. This malformation has been anecdotally reported in literature in association with Apert syndrome and hearing loss. We found similar malformations of the vestibule and lateral semicircular canals in 5 out of 6 patients with Apert syndrome in our population. The posterior semicircular canals were normal, and the findings were confirmed on CT. Here we can see a beautiful image of the facial nerve canal course on the inverted black bone. We can identify the labyrinthine tract, the geniculate ganglion, the tympanic tract, and the mastoid tract. If necessary, the 7th and the 8th cranial nerves in the inner meatus can be imaged within the same MRI examination. Notice that this patient with Apert syndrome also has lateral semicircular canal vestibule dysplasia. The vascular foramina assessment of the temporal bone might play a role in the evaluation of craniosynostosis patients. Jugular foramina narrowing has been described in craniosynostosis, and some authors argue that it might play a role in the pathogenesis of the intracranial hypertension. In this patient, we see a normal jugular foramen, and the flow void of the jugular vein can help its identification. In this patient with HUVE1 mutation, we see a bilateral narrowing of the jugular foramina that is confirmed on CT. Notice on coronal tissue the small transverse sinuses. We did not find pathologies affecting the carotid canals. And black bone also presents with limitations. The most important, the limited evaluation of the structures at the airborne interface. In this patient with the Cruzon syndrome and external auditory canal atresia, the malformation is visible on inverted black bone due to the absence of air in the external auditory canal. We see that the bony canal is extremely narrowed and filled with the soft tissue. The finding is confirmed on CT, while the concomitant dysmorphic ossicular chain was not visible on inverted black bone. To conclude, the role of black bone MRI in the temporal bone assessment is still under investigation, but the amount of temporal bone malformations that we found in our population was an unexpected and very interesting finding. Temporal bone malformations are anecdotally reported in literature, and some authors in craniosynostosis and some authors argue that they might be left behind more serious problems that these patients have. This highlights the need to systematically evaluate the temporal bone in these patients and to correlate the findings with the hearing problems that these patients might have and that could affect this patient's life. These are the references. And I would like to thank Dr. Garman, Dr. Van Atten, Dr. Brennan, Professor Manara, Dr. Gaillard, and Professor Mathiesen for the contribution to this research and to this presentation. And thank you for your attention.